October. Hard to believe.
Already?
Hard to believe it's October already. It's our October webinar, and the subject is paediatric postural care. My name's Les Jones. I'm joined by my colleague, Rebecca Dunster. Rebecca is our CareFlex clinical lead. Also joining us today is Anna Goldsmith from Simple Stuff Works. I'll leave Anna introduce herself in a few seconds. Just before we start, there's an awful lot to get through, so I won't hang around. A little bit of virtual housekeeping. Your cameras, mics should be switched off. We are filming today's presentation.
We do upload them to our YouTube channel, so and share those links.
And we'll share the links a little bit later. If you've got any questions at any time, my colleague Jess is manning the chat feature, so please feel free to post. If that's a technical issue, or if there's an issue there where you'd like to have a question resolved about the content of the session, just post it, then we'll pick it up towards the end of the session. In terms of technical problems, what we seem to find works best is just leave the meeting and sign back in. For some reason, it just seems to reset things, and things seem to work quite well. So without any further ado, I'll pass you on to Anna, and you'll see Rebecca and myself in about 20 to 25 minutes.
Brilliant.
Over to you, Anna.
Thank you so much, guys. Really appreciate it. Hello, everybody. I'm just going to load my presentation up and hope that it's all okay. Always the stress of technical issues, but hopefully we're okay here. Yes, we're all good. Hopefully you can all see that. So thank you so much to everyone at CareFlex for allowing me to join you guys today. It's fantastic to see you all, and it's great to see such a brilliant turnout. So my name is Anna Goldsmith, and I'm one of the directors here at Simple Stuff Works. So we are a training organisation specialising in what we call therapeutic positioning in the lying posture. So we don't do seating. We hand over to the fabulous experts at places like CareFlex when it comes to seating, but we look at the lying posture. So the reason I think kind of why we're kind of joined up today with CareFlex is because our lying posture and our seating posture, all our seating stuff, they go hand in hand. And so it's absolutely fantastic to kind of come together today to explain a little bit about kind of how the lying posture affects seating and how your seating can affect lying. We've got quite a lot to get through, so I will probably talk at the sort of speed of light, but don't panic. We've got loads of resources to share with you afterwards, so don't panic too much if things kind of go quite quickly. So I'm just going to quick copyright statement there. Okay, so why are we here today? So we're going to think through what postural care is. Now, people often kind of sit up a little bit straighter when I start talking about postural care. But when I'm talking about postural care, I'm talking about, like I say, protection of body shape. So we're going to think about how the lying posture and our seating can work together to provide the best postural care for the children that we're supporting. We're focusing on paediatrics today. I'm going to look at some fantastic best practice as well. So very quickly, a little bit about kind of who we are as an organisation. So myself and my sister run the organisation with our fantastic colleagues here. We're the daughters of John and Liz Goldsmith. So some of you may have heard of them, some of you may not have. My mum is a physio and my dad is an engineer. And together back in the 1980s, they designed some of the world's first sort of multi-adjustable seating systems. And back in the 90s as well, the first sort of humane nighttime positioning system. So myself and my sister have written accredited training courses in therapeutic positioning, and we kind of work internationally, raising awareness of kind of what postural care is all about, following on the work of mum and dad. So we've got a really long kind of pedigree in this, and like I say, we just look at the lying posture. We don't do seating, but I can hand over to the other experts on that point of view. So our principles of postural care are very simple. So we've got 24 hours in a day. And essentially, if you think about kind of, the length of time that children are at school, the length of time that children are then with their families, generally people are spending 3 times longer in bed than they are doing anything else. So obviously, if we don't get the lying posture right, then essentially gravity and time is against us. Okay, so we need to kind of think through what is happening at nighttime. And very often it's been missed, or it's been kind of not necessarily on the radar because it's nighttime, it's 2 o'clock in the morning, it's happening behind closed doors. And we've got to really think through how do we highlight to people the importance of those long hours of nighttime and how we can use them. So the lying posture really has often been the missing link for a lot of people. So we might have some incredible seating systems, some fantastic alternative seating, but if we're missing lying, if we're missing lying down, that's a huge chunk of time. So it's really interesting to kind of see how the two things kind of marry up. I can guarantee you that problems that we start to see in the seating kind of, seating world, they'll probably have their root causes in the lying posture, because basically the way that somebody lies down becomes the way that they sit. The way that someone then sits dictates what they can do, where they can go, the sort of pain they might be experiencing, how they can kind of participate in everyday life. So the lying posture is the blueprint, and I'd like us to keep coming back to that concept of making sure we've got that lying posture right. So people will often say to us, who's the kind of, who's at risk here then of developing, changes in body shape and problems with postural care? And really, it's really simple. So often in paediatrics, people will kind of look at children who have sort of gross motor function scores of kind of 4 and 5. So looking at our very complex children. And actually, it's kind of all children who have a slight movement difficulty are at risk here of developing changes in their body shape. Our risk factor is a little bit of hip and knee flexion. So if I don't have hip and knee flexion, here's my little skeleton here. If I lie down, I can make full contact with the bed and everything's absolutely fine. Doesn't matter what position I'm in, I can make full contact. If I have a little bit of hip and knee flexion though, and I can't fully straighten my hips and my knees, when I go to lie down, I need to do something with my legs to take the weight of them. So the great thing about body shape distortion is it's a series of patterns. So what people will do, what you'll see children doing, is opting for one of 3 postures. So some children will bring their knees together. Some children, if they have quite low tone, their legs will fall out to the sides in a sort of frogged posture. And quite typically people will windswept. So you'll see children where both legs will fall to one side or the other. Each of these patterns of distortion will lead to further complications in somebody's body shape, okay? But it's really important to remember that from a risk factor point of view, it isn't our most complicated children who are only at risk of this. It is children with a little bit of hip and knee flexion. That's your big red flag. So these are what we call destructive positions. So these positions are probably quite familiar to a number of you. They tend to be asymmetric. They tend to be unsupportive. So we'll see an increase in tone, which we'll talk about a little bit later on. And you'll also increase your pressure injury risk when children end up in these sorts of postures. Now, people often say to us, well, what's the big deal? Kind of why, particularly if you imagine if you've got a little child who has been using their wheelchair all day and then they come home from school and there's other activities for them to do. When they get into bed, it's quite kind of common that people think, well, I just want them to lie down, however they want to lie down. The thing being though is that those sorts of destructive positions over a long period of time can cause catastrophic changes in people's body shape. Now, here in the UK, the LEADER inquiry, which looked at premature death for people with complex needs here in the UK, found that respiratory failure is the biggest killer of people with complex disability here. And body shape distortion has been directly attributed to causing respiratory failure. What I've got here is a series of x-rays just to show you kind of what body shape distortion is. And it's really important that we understand that this is our enemy. Okay, this is what we're up against. So when I'm talking about postural care, I'm not just talking about kind of keeping people a bit more comfortable or just, we're not looking at symmetry from an aesthetic point of view. We're looking at symmetry and protection of body shape because it prevents premature death. So you can see here, we've got a young man called Fred. His chest is looking kind of pretty spot on here. Everything's kind of where it needs to be. Fred, age 10, you can see how his spine is just starting to curve. It's just starting to pull round to his left there, but it's very subtle. We could at this point measure his chest shape and we could find this kind of asymmetry there, but that wasn't available to Fred at this particular time. Fred, age 17, so you can see there how, his ribs and his hips have made contact, his chest is collapsing and rotating. The contents of his abdomen has been pushed up into the space reserved for his lungs, so his right lung's no longer functioning. So this is respiratory failure, kind of, right in front of our eyes here. Fred, age 21, Fred, age 23. It won't surprise you to understand that Fred died about 3 weeks after this x-ray was taken. Okay, Fred's body shape simply isn't compatible with living. So most people start off symmetrical. So we have not only a duty of care to protect children from these avoidable changes in body shape, but really excitingly, using the lying posture, we can also restore body shape. So I promise you, from now on, it all gets far less grim. It's all very positive as we kind of move forwards now. So really simply, effective nighttime positioning is going to be more symmetrical. It's more supportive. We're going to spread the weight of the body over a much larger surface area. We're going to massively increase somebody's proprioceptive feedback, which helps from a tone point of view. And we're going to decrease our pressure injury risk as well. But I can guarantee you, one of the first things that comes up when people see these sorts of images is people will start to say, well, I couldn't sleep like that. I don't think I'd like the look of that. It looks a bit peculiar. Nighttime positioning equipment looks very different, you know, if you're just not used to having anything in bed. And one of the first barriers that comes up is people will often say, I don't like the look of it, or it looks a bit strange, or it looks a bit restrictive. And we kind of like, we have to come back to this idea of, you know, I've got 2 children who, when they're babies, I pop them in car seats because I've seen those crash test dummies that, you know, kind of tell me why I need to do that. Body shape distortion is simply a slow car crash. So parents have a right to know what's the risks associated with leaving their children unsupported at night time, and what benefits can we achieve by using some equipment that could be described as restrictive. Only then can families make an informed kind of judgment about whether or not they want to utilise therapeutic positioning equipment. We're doing a little bit of biomechanics here. Don't panic, it's not too heavy, but it's really important to understand kind of what's happening to the body and how we can use the lying posture to make positive changes to the body. So generally, all of us have very, very flexible and dynamic chests in particular, okay? So your chest is mainly made up of cartilage. Your sternum doesn't ossify till you're in your 40s. So it's a very vulnerable structure. And because of its vulnerability, it can change shape very, very easily. So generally though, when people are lying down, this is what we're after for people, okay? We want what we call stable equilibrium in supine, so balance. We want people to be able to balance when they're lying down. When we're lying down, our pelvis should be level, our chest should be symmetrical, and there should be an imaginary line running from the sternum to the spine, and that should be vertical. We're going to keep coming back to this line because this line's really important to understand how we can change someone's body shape for the better by utilising this line. So this is what we call stable equilibrium. But obviously, most people don't sleep like that. So what happens is everyone's body shapes will distort when they go to bed. So when we all go to bed later on this evening, we'll get into bed, our body shapes will change. So you can see here, Abigail, little baby here on the left, her little leg turn and her head turn, you can see her chest has rotated. So her chest has moved across to her right-hand side, her sternum's moved across her body, her spine has pulled round and her chest has rotated. But you can see there for the gentleman who can't move as easily and who finds himself in that particular posture night after night after night after night, you can see how that normal distortion has become fixed and exaggerated in his particular chest shape. Now, what we have to think through, particularly when we're working with paediatrics, is people will often say to us, oh, well, you know, she really likes to sleep on her tummy, or she really likes to sleep on her side. And it's important to recognise that first of all, if you think back to that risk factor of some hip and knee flexion, these children often don't have a huge amount of choice about what positions they can adopt, okay? So they're kind of limited in the way that they can choose to adopt positions. And also what can happen is over a period of time, actually they haven't got a choice as to what position they lie in because their body shape has changed to such an extent they have, you know, it's obligation, they have to sleep in one particular position. So you can see here, James used to like to sleep on his tummy. So it's a comfortable, secure position for him. However, no one explained to James and his mum the impact of that particular posture over a 10-year period. So he's 9 in the first photograph and he's 19 in the second photograph. So you can see there, James has a very significant head turn, which is affecting his ability to swallow safely. He's got a long asymmetric lordosis. So, you know, when we're thinking about seating and lying, trying to get James into a comfortable seat, particularly with how flexed he's getting as well, getting James into a comfortable seat here is very, very challenging. And we're looking at having to use very complex seating systems to kind of get him out and about. They're also thinking about surgery to try and kind of, you know, help to sort of loosen his legs, and also thinking Botox and potential intrathecal baclofen. So there's loads of interventions going into James here, lots and lots of, you know, kind of added complexities to his care. But the elephant in the room here is that he's slept in a destructive posture for 10 years. Now, as people's body shapes start to change, we need a little bit of jargon to understand what's happening. So what we can see here is what we call clockwise rotation of the chest. So do you remember that sternospinal line that I was telling you about before that we want to be vertical? We can see how that's collapsing towards the person's left. The minute that sternospinal line starts to collapse to one side or the other, the chest wall mass will simply collapse down to the supporting surface. The spine gets pulled around in that scoliosis. 99% of the time, the chest will follow the direction of the legs. So in somebody who is wind sweeping to the right, the chest will tend to follow that direction as well. So that's what we can see happening here. And this is what's happening on the inside. So you can see there as the chest wall mass collapses down, it pushes the spine up and round into the space reserved for the lungs. The lump at the kind of the bottom of the screen there, that's the rib flare that you'd see along someone's back when you bring that person kind of upright to get into their seating. So here what we can see is anti-clockwise rotation. So you can see the sternospinal lines collapsing towards this individual's right-hand side. So again, you can see the chest wall mass just collapsing down towards the right. Now you might be thinking, why is she going on about this? Why is rotation so important? Rotation is absolutely fundamental to know about because, really excitingly, we can use the lying posture to correct people's body shapes, but we can only do that if we understand the rotational distortions that are happening to people. So we can measure, and we haven't got time to go into measurement today at all, but I've got loads of information I can share with you afterwards about measurement. You can measure from the xiphoid process to the lateral border of the chest, and we want that number to be the same on both sides. If we divide the right by the left and we get a 0 point something cancer, we've got anti-clockwise rotation, and a 1 point something cancer, we've got clockwise rotation. So what we can then do is, once we know about rotation, we can use our positioning system to de-rotate the chest. Now, it sounds like we're going to do something awful. I promise it's a very, very gentle process. So can you see with this young man here, how his chest is rotating in a clockwise direction? Now, I've seen time and time and time again, people putting in a couple of laterals either side and thinking, there we go, that's that fixed. And it's important to recognize that that's not going to do anything. Putting a couple of laterals either side of his chest there is going to do naff all, because it's not a lateral flexion that we're seeing here. We're seeing a rotational distortion. So we need to de-rotate his chest and bring that sternospinal line back upright again to get his chest shape back to where we need it to be. So what we've done here is we've blocked in the one side of his chest, the right side of his chest. Then we gently use his positioning system to gently roll him and bring his sternum back into the middle again, get that sternospinal line upright again. And then we block in the left-hand side. Now that third picture is really important because that rib flare that you can see there that looks really prominent, kind of up on the left-hand side there, that rib flare was there all along. It was just lower down on the supporting surface. We've made it look more prominent by bringing his rib cage round. But it's important that we say to people that that's normal. But if we keep doing this night after night after night after night, you make a huge impact on someone's body shape. So this young man here is 25. His chest was collapsing in an anti-clockwise direction. And you can see there how we've brought his chest round over a period of 3 months. And can you see how his chest is wider? It's more symmetrical. His breathing is better. You know, everything is looking, you know, sort of fantastic for him here. The key thing though for this young man is he didn't fit his custom contoured seating anymore because his body shape had improved so much over the night time, but it wasn't keeping up in the day. So making sure your seating and your lying posture are working together is so fundamental, you know, to make sure that people can kind of, you know, like Harry here, he couldn't get out and about for months while they waited to update his seating because his body shape had improved so much. So what about kind of different postures then, you know, that we need to kind of think through? So first of all, if we're thinking through positioning and we're thinking through kind of, you know, what is the kind of aim when it comes to the lying posture, I'd sort of say straight away that if we can, we need to try and avoid side lying as much as is physically possible. For some people, side lying is the only safe option because of the risk of aspiration. So we need to kind of, you know, obviously we'll use the lying posture to limit the damaging effects of side lying, but generally over a long period of time, side lying is very, very challenging for people. So if you look at each of these different options here, people will often say, oh, we do symmetrical side lying. Symmetrical side lying is a myth for a start. The closest you'll get is that kind of fetal side lying position you can see there, but that tends to change. The minute that person gets a little bit bigger, the weight on that bottom shoulder means that they'll tend to swing the shoulder one way or the other. So you get lots of rotation through the body. If you want to give someone pelvic obliquity, go for your middle picture there. You know, this is the thing, you know, this side lying is just riddled with rotation, compression, all sorts of complications. If you're thinking from a seating point of view, if you want to know whether or not someone's lying posture is any good for them or not, think to yourself, how would I get this person into a comfortable seat? So if you look at each of these three options here, it's going to be really challenging to get Tom here into a comfortable seat, because there's lots and lots of things to undo, first of all, to get him into a position where he can be sat comfortably. So side lying generally isn't our friend for long periods of time. It has its benefits for daytime positioning and things like that, but not for long periods of time. If someone can be positioned in a different position, then we need to aim away from side lying. So what about prone lying? So prone lying, once again, I'm going to sort of state my case quite early and say no. Prone lying for long periods of time is, again, incredibly damaging for the body, okay? And simply because we've put all the heavy stuff on the top. So straight away, you can see this young man, he's got that typical head turn, typical arm posture, long asymmetric lordosis. This is the kind of, again, you'll go around and you'll see kids now, and if, arms like this, head like this, asymmetric lordosis, you know they sleep on their tummy. For this young man, when you go to feel his stomach, you can feel the vertebra of his spine through his stomach, okay? Because all of the heavy stuff simply collapses down and compresses all of the soft stuff underneath, okay? So prone lying for long periods of time, once again, is not our friend. So if it's not side lying and it isn't prone lying, clearly leaves us with lemon meringue pie, obviously. Now we use this analogy a lot when we're working with families of small children. The complexity of the children that we support, that, you know, children are getting more and more complex in terms of their medical need. And very often it means that we're missing some of the really simple solutions. So think back to James, who was lying on his tummy. You know, we've got Botox going in, we've got really complex seating, we've got surgery, we've got a peg because his swallow's getting really unsafe. We've got all these medical interventions going into him, but actually his positioning was the kind of root cause of most of that. So the lemon meringue pie principle is this idea that if you put a lemon meringue pie in the fridge upside down, it won't look like one in the morning. And if you put it in the fridge on its side, it won't look like one in the morning either, because we need all the heavy stuff on the bottom to protect all the soft, fluffy stuff on top. And that's exactly the same for the body. We need the spine, the pelvis, the scapula, all of the heavy stuff on the bottom, so that this very vulnerable structure on the top, this soft, fluffy stuff on top, can be protected. So effective nighttime positioning, you can see there, supported supine lying is the way forward. Now, for some people, it's going to take a long time to build up to supported supine lying, but this is always got to be the aim. It has to always be the end goal for people. Not only is supported supine lying fantastic from a protection of body shape point of view, but it's also fantastic with regards to helping to turn the volume up on people's touch perception. So the parietal lobe here on this particular screen, this is where the body kind of helps to orientate itself. So if you have a neurological condition or neurological damage, very often your proprioceptive feedback loops are not quite firing properly. So what we need to do is make sure we kind of help to sort of contain people, give them lots and lots of proprioceptive feedback, and you will see people's tone come right down. So it's a fantastic kind of, not only do we protect people's body shape, but we also have a huge impact on sensory feedback as well and tone management. So very, very quickly, just a couple of stories, and I'm aware that I'm kind of running over, so I'm going to go really quick. This is lovely Colleen Annette. You can see here she's got that anti-clockwise rotation in her chest. She's got her legs wind sweeping. Her tone is high. She would arch and extend into the mattress if she had no support. A couple of minutes later there, we've got her really well positioned. We've done that derotational force there into her chest to get her nice and symmetrical again. And fantastically, you can see here, Colleen, 4 years later, just how sort of relaxed, how symmetrical, and how fabulous she is. The hippo that you can see there, our leg supports are based on him. So whatever he was doing, it was working so beautifully. We've got souped up hippos in the form of our supine stabilizers. And very quickly, got the lovely Tommy here. So Tommy used to sleep in a really tight curled up fetal position. And you can see there a period of 2 years of gradual derotation and bringing him back into that more midline position. Tommy at age of 42 there is looking absolutely fabulous. So, you know, while we're talking about pediatrics today, it's never ever too late. Is it working? So do we do measurement of body symmetry? Have we got families that are really confident and competent in what they're doing at 2 o'clock in the morning with their nighttime positioning solutions? Are we seeing direct impacts on things like surgical intervention like they do in Wakefield? So Wakefield services have an incredible postural care service. which is kind of their seating systems, their nighttime positioning systems, and their orthopaedic consultants all work together. And they have seen a dramatic reduction in surgical intervention for children in their services. Are we seeing reduced secondary complications? All of these things will prove that your nighttime positioning service is doing what it needs to do. So I'm going to stop talking and hand back over to the fantastic team at CareFlex. But thank you all so much for your time. If we can get the lying posture right for people, honestly, like the world really is kind of your oyster. It is really powerful. So thank you all so much.
Thanks, Anna. That was fantastic. It's every day's a school day, and today's certainly that for me, and I'm sure it is for everybody else who's watching as well. So we'll have a chance for some questions and answers at the end of the presentation, but I'll quickly pass you on to my colleague Rebecca, who will run through the seating side of today's topic. So
thank you,
Rebecca,
Les.
over to you.
Thank you, and thank you, Anna. That was amazing to see all those visuals. I think really just put things in context about how important it is to be proactive with postural care and to actually think about that full 24 hours as well. Let me just get a presentation. So what we're going to do now then is really try and put that into context with seating and see how we can come up with some solutions for some of the postural challenges that we commonly see in the seating world. I'm just going to switch the video as well so you can see me on the screen. There we go, brilliant. There we go. Okay, so just to quickly recap then, same principles as what Anna went through there about postural care when it comes to seating, is that holistic use of any technique, in this case the seating system, to minimise postural abnormality and enhance functional movement. So our aim is to preserve and, as Anna said, even restore body shape for individuals who present with movement difficulties. And body distortion is not inevitable. If we can get the right equipment in a timely manner with the correct positioning to take across that full 24 hours, then we can help protect that body shape. And it's important because it is directly related to a person's health and well-being and work quality of life. So when individuals sit or lie in unsupported postures or asymmetrical postures, they can experience all these secondary complications that come with that: pain, fatigue, increased dependency on the support network, and even poor physiological function. And Anna touched on that amazingly as well when we think about physiological function with somebody's respiratory ability, their digestion, like even their cardiac efficiency. So gravity, especially in seating as well, its effects can trap individuals in those destructive postures. We exaggerate asymmetries, and then that can lead to the unequal loading on tissues and increase in pressure injury risk too. Now, there are going to be significant psychological, physical effects on poor postural care, which in turn will have severe and life-threatening consequences. Anna mentioned there about the review, the inquiry that happened, and it's believed that around 52% of individuals with a learning disability die prematurely from this respiratory related condition. So as a physiotherapist who comes from learning disabilities, this is where my passion comes from. I also have a personal stake in this with a younger sibling with PMLD, with profound and multiple learning disabilities. So to really drive the awareness on the need to be proactive with postural care, but then address it all those postures across the 24 hours is really key. Now, what is specialist seating then? So it's critical to an individual's quality of life. When a child or a young person's ability to achieve their optimum positioning is affected, whether that's through their illness, injury, disability, it can have a significant impact on their health and well-being. And ultimately, in the simplest of terms, specialist seating allows children and young people who might otherwise have difficulty to sit out to achieve their optimum sitting posture. Now, it's a $1 million question. What do we mean by good sitting posture? I use that term loosely because obviously this is a gold standard checklist, and it's not easily or realistic to achieve in some of our clinical practice if we are working with more complex individuals. But what we're aiming to achieve is their optimum sitting position. The body is conformed to the supporting surface as symmetrical as possible. This means that the body weight is distributed equally and over the maximum surface area, so as much of the body is in contact with the chair as possible. The body is balanced and stabilised, but it can still adjust to change, so still able to reach outside of the base of support while still remaining stable within the chair. all those body segments, and we'll go through them a bit shortly when we look at postural support, but all body segments from the pelvis down to the feet and up to the head are supported and aligned as much as possible. But then the upper limbs are also free from the low bearing role. Again, we'll talk a bit about that when we look at function. So if we just look at some before and after photos, just so visually we can see what we mean by destructive sitting postures, and then hopefully aiming to achieve an optimum sitting posture. And again, this is going to be gold standard, all those different checklists you can see on either side, because in complex cases, we're just aiming for the optimum sitting position. And sometimes there's a compromise as well. And it's probably one of the words that's the high bad to adjust to when it comes to postural care, because as a physio, sometimes you really focus on getting this perfect sitting posture, where actually we need to think holistically about how we achieve our objectives while still putting the person at the centre, making sure that we're achieving all their goals as well. But as you can see, getting the body supported as upright as possible, full contact with the chair, being able to open up the shoulders and the shoulder girdle, supporting the arms where appropriate, allowing them to be free from the low bearing role, supporting the trunk and spine, and not forgetting the feet as well, getting the feet supported. This is really key in sitting. So when it comes to paediatrics, I mean, when we're working with children and young people, the seating objectives can be slightly different because we are trying to be proactive with the approach. So what we've got, and it's one thing at CareFlex that we always put as top priority, is comfort, because it is entirely subjective, but it's actually the key driver for compliance with equipment. And we won't achieve our clinical objectives if the individual we're working with isn't going to use that piece of equipment. So we've got to get that comfort. Then protection, function, and then engagement. So really thinking holistically about all aspects of that person's daily life, from the physical to the social, and to the psychological factors as well. So some of the seating considerations that we need to ask ourselves. I just wanted to say quickly as well that we've been doing these webinars now for 2 years, I think, Les?
At least.
Yeah, for 2 years. So we've got a whole other sessions as well that goes into more of the clinical justifications around seating. So I'll be touching upon some of these things, but if you wanted access to actually more detailed clinical justifications, the clinical reasoning for seating, then please do let us know. We can send those webinars out. Our last webinar, we took it right back to the basics and the 10 things you need to know about specialist seating. So if there's any terms or anything I'm using, then please let us know. We can send out more information on them. But when it comes to seating considerations for paediatrics, these are the main things that we need to be thinking about. So ultimately, how will the chair fit into daily life? How can we make sure there is consistent and compliant use of that piece of equipment from an individual, but also the support networks? We would be heavily relying on the support network to utilise that piece of equipment. So how will the chair fit into daily life? How do we differentiate the seating system and integrate it with other equipment? So Anna was talking then about lying postures, but there are many other hours during the day as well that we need to consider. And especially when it comes to specialist seating, there's going to be different objectives to maybe somebody's wheelchair or their high postural support dynamic seating. So it's very different goals and objectives, and we need to differentiate that, because a key part of postural care and pressure care is repositioning, is about achieving different positions throughout the day, which are also supportive and taking us away from those destructive postures. How will the child transfer into and out of the chair? Because that will then dictate some of the functions that might be needed, or the different sizes that might be needed in terms of the setup. So if somebody is hoisted, for example, then do we need tilt and space to aid with that manoeuvre to be able to get the pelvis, utilise gravity into the back of the chair? Is somebody still ambulant? Are they still able to transfer independently? Do we need to think about the seat height of the chair to make sure that we're encouraging that movement? Is there something to do with side transfers? Do we need things like removable arms? Steadies is another one as well that we need to be mindful of. And again, that's part of the assessment process and making sure that we can integrate it with other pieces of equipment, especially when it comes to movement and handling. We need to think about the level of postural support that's required, and that will come down to obviously the postural assessment and how the chair will fit into that 24 hours. What kind of support do we need in sitting? And as Anna said, it's all interlinked. So how somebody lies is how somebody will sit. So we need to be thinking about how we maximise all those different postures to get an optimum position throughout that full 24 hours. Are there any pressure care needs? Are there any concerns around skin integrity, especially when it comes to unequal loading on tissues, particularly? Is there a history that we need to be mindful of to make sure that we are addressing all those high pressure areas? We need to think about the physiological function, activities that need to be supported within the chair. Again, this is really relating to how the chair will fit into daily life. What are the hobbies and interests of the child? What do they want that chair to enable them to do within the home to be able to continue with the activities that they enjoy? Because otherwise they're just simply not going to want to use that piece of equipment. We need to think about the usability and then maneuverability by the support network if we're relying on them as well, especially within the home environment. How are we actually going to get the chair into the environment? Gravel pathways is a huge concern of Les's. So how do we get the chair into the environment? Is there space to manoeuvre the chair between rooms, especially if a child wants to use the chair in the kitchen or the living room? Another key thing as well is making sure there's space to utilise the functions appropriately. So things like back angle recline, leg rest, elevation and tilted space can increase the footprint of the chair. So we need to make sure that we're not causing any hazards there. And also the growth potential of the child, young person as well. So we need to, as best as we can, future-proof equipment, making sure that we can be flexible, being able to add or remove functions and accessories retrospectively as different conditions progress, or even if there's rehab potential as well. And then space for the chair, and we touched on that within the home environment. Okay, so let's look at those 4 key areas we mentioned. So first of all, comfort is essential, and this is what's key for quality of life. So if we can promote comfort, if we can encourage those feelings of safety within the chair, then we can not only enhance daily life, but we can also increase the tolerance of a desired sitting position as well. One thing we always get asked about seating is about guidelines for sitting out, and it's totally independent on the individual. But one thing I would say, if somebody has not had access to alternative seating, to specialist seating before or for a period of time, then we do need that gradual introduction to increase that tolerance and compliance as well. We can't expect somebody to just sit out straight away in a chair for 10 hours throughout the day. We need to make sure that we are gradually increasing that tolerance, but also then still thinking long term about whether we need to change position throughout that 24 hours as well. And we can support people if people are needing support with care planning and guidelines and so on. Ultimately, research has shown that if the individual isn't comfortable, regardless of all those clinical benefits that we are trying to achieve, they will simply not use the chair. So really, that's why comfort is a key priority for us at CareFlex. And if there's something I wanted to quickly mention here was about, especially when it comes to comfort and compliance with equipment, is aesthetics of the chair. Is this a luxury, or is it actually really important for the provision? Now, it could really be critical to compliance, especially if you're working with children with ASD, or maybe those with sensory impairments. Different fabric textiles and textures, certain colours and patterns might actually be really important to their willingness to use a piece of equipment. And as long as we can clinically justify that, then that's certainly something to think about. As clinicians, we often work in environments where maybe their standard go-to is brown or black or grey chairs, but actually if there's a clinical need for compliance, then we can clinically justify that. And it's just something worth thinking about, especially when it comes to familiarity with colours, certain patterns, especially maybe if somebody has visual problems, for example, or even sensory impairments. So it's just something to think about, and it certainly can be clinically reasoned if aesthetics is a key part of that. So the next objective we had was protection. So this is about protecting body shape. So I'll be following on from what Anna said in sitting, but also protecting health and well-being as well. Now, what I wanted to do was just spend some time looking at some of the common postural challenges that you might come across when individuals are sitting out if they are in unsupported seating surfaces. So one is pelvic rotation. So this is where one AS is more forward than the other. So the anterior, let's get the, show it here. I need to stand back a bit. The pelvis there, at the front of the pelvis. these bony prominences right at the front of the pelvis. When one is more forward than the other, we get that rotation. And while I'm here as well, just explaining about obliquity, when one of these ASASs is higher than the other, that's the obliquity. So the pelvis, I'll chat about in shortly, but the pelvis is the foundation for sitting when we're talking about sitting postures. So what we want to make sure is that we are familiar with the pelvis and where possible, getting hands-on to actually get the feedback that we need to understand what the pelvis is doing and whether we can correct or whether we need to accommodate. Thank you. So pelvic rotation, one side more forward than the other, and it can often be associated with pelvic obliquity, especially when we have complex pelvic challenges. We will see a lot of these movements in different planes happening together. It can also be associated with spinal rotation, because as we know, all the body segments are interlinked and one will dictate what happens to the other. We could see with wind sweeping, and also in individuals who actually use their functional lower limb to propel themselves within the seating system or within the wheelchair. It can also be found in individuals with leg length discrepancies, but we need to be really careful here to find out actually, is it a pelvic involvement or is it just a leg length discrepancy? And that will come down to the postural assessment, because what will happen if there's a rotation, one leg will appear, one knee in sitting will appear more forward than the other. So we just need to be mindful of actually, is it true pelvic involvement or is there a leg length discrepancy happening? And this is when I said about obliquity. So you can see in the image there, one side of the pelvis is higher than the other. And again, associated with pelvic rotation, especially if somebody's maybe got an asymmetric trunk, if there's a scoliosis or a weakness with leaning to one side or high toe pulling an individual into that position. Fatigue as well, because we might see them just dropping down onto one side and the pelvis automatically goes into our obliquity. It can also be seen with if individuals have pressure areas as well as an indication on one side. What we might find is that ischial tuberosity on the lower side of the pelvis. Obviously, there's higher interface pressures, so it could be associated there with pressure injury. Now, as I said, the pelvis is the foundation for good sitting postures because it dictates what happens to the body segments above and below. It's positioned at our core and it acts as that support system for the entire body. Now, when it comes to seating solutions, I won't go into too much detail because I think it'd be better for you to see Les showing you visually what those seating solutions actually look like and how we can utilise them within the support system. But essentially what we're trying to do is support the pelvis in all planes of movement and get it stabilised at the back of the chair. So different functions, and we'll cover it shortly with Les, that can help with pelvic instability, because hopefully what we're aiming to do is correct, especially when we're working within paediatrics, identifying the risk, being proactive and gradually correcting those postures to restore body shape and reduce the risk of that body distortion happening. Those of you who have worked in both, maybe in adults and paediatrics, and seen the whole spectrum and actually what can actually happen if we aren't proactive and if we aren't addressing body distortion in a timely manner, actually what can the destruction not only to body shape, but actually to the health, well-being and premature death as well. So it's a responsibility on us as well to get in there and be proactive and make sure that we're identifying risk and supporting the body in all those postures across the 24 hours. Things like tilt in space, we can utilise gravity to get pelvis at the back of the chair. I've got some asterisks there for tilt space and positioning aids because they're functions that we have to be really careful in prescribing. And when we go through practically, so you can see what tilt space does, I'll just explain a bit more detail. Positioning aids, things like 4-point pelvic belts, 2-point pelvic belts, groin harnesses. There are safety device alerts for these types of accessories. So you have to be really careful and responsible about prescribing them and handing them over as well. Ramp seats can also help to stabilise the pelvis, contoured cushions. Another thing we always mention at CareFlex, and it's actually one of the basics of seating systems, is to get the seat dimensions appropriate for the individual. And it's something that can often be overlooked, especially if there's multi-user environments or if an individual uses different equipment throughout the day and they move in between different equipments, we need to make sure that that chair is set up for them. things like seat depth, seat width, and seat height are critical to pelvic stability. If we have seat width that's too large, for example, then we're giving them the pelvis room, especially if there's instability there, to wiggle within the seating system, and we can actually cause that rotation and that obliquity to happen because we're not stabilizing it. The same with seat depth. If that's too long, for example, and the child can't actually physically bend the knees over the edge of the chair, then they're going to go into that posterior pelvic tilt into sacral sitting just to be able to get their feet on the foot plate. So it's really key that we get the chair dimension set up. We've done a webinar, I think it was before the summer, that was on appropriate use of chair functions and accessories and setup. So that's probably a good one as well if you're new to seating, to understand the basics of that, when certain functions are appropriate or when they might be contraindicated, or if there's precautions around that. So this leads us on to health, so protecting an individual's health. Now, a major goal in postural care is to enhance that autonomic nervous system function. If an individual is unable to maintain an upright sitting position, then we could see a decline in their overall health, and this would be reflected in their physiological function. Now, we have to have good postural care, especially sitting upright, for physiological function, because there's lots of research out there that shows that sitting upright, sitting in a midline position with the head supported, can facilitate physiological function. Things like normal swallowing patterns, safe eating and drinking, respiratory function, so their breathing ability, and even things like cardiac efficiency. Anna showed us some lovely, I say lovely, not lovely, maybe give me goosebumps seeing some of those x-rays, but just again to visually just show you the impact that trunk asymmetry can have, and then all the distortion that's happening at the organs, and actually how are we expecting individuals to have optimum health and be able to breathe well and eat and drink safely and have good digestion if actually we aren't protecting their inner workings. So it's not just about the aesthetics, it's about making sure we're protecting their health and well-being, and making sure that we are doing our best, especially when it comes to, I mean, the inquiry with premature death. We really have a responsibility to be proactive and stop things like this from happening. So what are some of the things we might see when we do a postural assessment, when we get someone sitting out, especially when we look at their postural support, getting them sitting out and seeing actually what the effects of gravity can have on them. Individuals who, especially when we're doing full postural assessments in lying compared to sitting, there's always indications of what somebody would be able to sit like from their lying posture and so on. But what we can see is something like a scoliosis, that there might be a lean, an S or a C-shaped curve to the spine, which when looking at someone will look like a lean into one side. The reason we get hands-on and do our assessments and feel into things like the spinous processes is to understand whether this is a C shape or an S shape, because that will determine what kind of lateral support might be needed and where those apexes need to be to get the impact that we need. And we might see protruding ribs on one side, uneven shoulders, and it's often associated with that pelvic instability, so with a pelvic obliquity, with those rotations, and also pain as well. Another key part of scoliosis, as we know, we can see from the x-rays and the distortion that's happening in the organs, is actually the impact that it can have on respiratory and digestive problems. So some of the seating solutions, when we think about trunk alignment in sitting, and again, we'll see them a bit more clearly, but different back support options, from contoured backs to flat backs with lateral supports. Positioning aids like chest harnesses can also help as well if somebody's got a pelvic belt as well, to give the proprioceptive feedback that somebody needs to open up the chest girdle and remain in contact with the chair. Tray, some anterior support as well, like a tray, padded trays, V cushions can also give that feedback that might be needed to maintain upright and keep in contact with the chair. Moving down then to the body segments of the lower limbs, a common one that we can see is windsweeping, and Anna obviously touched on that. And this is my sister's lovely legs in lying, obviously exaggerated and without any support, but windsweeping where there is a abduction and external rotation of one hip and the adduction and internal rotation of the other. So basically the legs give the appearance they are being windswept to one side or the other. But it's worth remembering, especially in sitting, that it's a whole body system postural challenge. So it's not just about correcting, if possible, the lower limbs. Actually, we need to think about the pelvic association, the rotation at the trunk that could be happening, and also the head support as well. So we need to still target all those body segments to correct or accommodate where needed. And manage windsweeping can have a whole host of problems, from pressure injury risk, especially in the groin region, if we're not separating the thighs and getting good thigh alignment, but their overall postural deterioration as well. Because as Anna said, where the legs go, the rest of the body tends to follow. Some of the seating solutions we can look at for the lower limbs, still working on the pelvis, because that will dictate what happens to the body segments. Getting that pelvic stability, maybe contoured cushions might be indicated, pommels, whether that needs to be offset or angled as well to accommodate certain postures. But the goal is obviously to gradually correct those, especially within paediatrics, to try and get their optimum positioning and reduce the risk of body distortion. We might need to increase seat width, especially if somebody has sadly become fixed in certain postures, if they've lacked that postural support and they're coming into the service and they've developed these really fixed complex deformities. We might not actually need to increase the seat width to protect the knees, but just make sure that then we build in at the base to stabilise the pelvis, the seat base to stabilise the pelvis within the seating system. Things like step seats might be indicated for the lower limbs, especially if there's maybe a rotation, a fixed rotation or a leg length discrepancy. And things like W trough lower leg support as well can be added to seating systems. So something like this, just visually, just to show you. Les will touch on it as well. There's obviously standard seating solutions. At CareFlex, we have a tailored seating solution service where if something bespoke is identified, some modification is needed to a particular accessory or even the structure of the chair, then that's something that can be discussed on obviously an individualized basis. Contractures. Contracture is a clinical term which means, in the simplest of terms, a limitation in the passive range of movement at a particular joint. Now, contracture development has got many different factors. It's really complex, and a number of structures can be involved, from the skin through to the tendon, to the muscles, and even the joint capsule itself. And sadly, when it comes to that, it can often be irreversible. So that's why, especially within paediatrics, we've got this role to play to identify the risk and make sure that we are putting in postural care in a timely manner to reduce this very thing from happening. Because sadly, if individuals are unsupported or if they come into the service as an adult in these positions, how are we meant to be able to get them sitting out? How are we meant to get them supported in lying or being able to engage in activities when they could be confined to the four walls of one room? So we really have this responsibility in paediatrics to identify that risk, which follows them through into adulthood, to make sure that we are giving them the best chance to manage their posture, but to also engage and have good quality of life. When we are talking about contractures, on any seating assessment, really, one thing we do need to consider is the critical angles for sitting. One thing that will happen is if you do get in touch with CareFlex is that you more than likely will speak to somebody like the lovely Jess, who is with us in the chat function on the phone, and she will ask you a series of questions about somebody's presentation. It's really key for the seating assessors to know beforehand what type of challenges they're going to present, because there's a whole host of functions and accessories and setups, and we can't bring all of those to the seating assessment. We want to maximise that time with you, so we need to know specifically about their ability to achieve hip flexion and knee range of movement, but also that wind sweeping, so thigh alignment that we mentioned, but also foot support as well, so they know they can bring out everything that's needed for that assessment together to get the most out of it. Some of the things then, so when we talk about hip and knee range of movement, we also we can talk about hip flexion contractures, or maybe they have actually difficulty opening up the hip angle. So there are different options. If somebody is unable to get to that 90, I mean, we say about this gold standard 90 sitting position, which I'm sure if we put the cameras on all of you right now, nobody would be sitting in that position. But this gold standard position, if somebody can't achieve that, there's something like back angle recline could be indicated. We might need to ramp the back to open up the hip angle or close the hip angle, especially if things are becoming fixed, which hopefully our role here within paediatrics is to stop that from happening. Maybe split leg rest might be needed if somebody does have different ranges of movement in the knees. We can try and correct and accommodate at the same time to make sure that we are fully supporting the body system to maximize that range of movement. Things like negative angle leg rest might be indicated, chamfering cushions, and then really down to bespoke things then like hanging footrests, which I'll just show here, which is again part of our tailored solutions, where we actually entirely remove the leg rest section. So somebody's got really tight knee contractures, obviously their foot then placement will be under the chair frame itself. We can remove that foot plate, the leg rest, have a hanging foot plate to support the feet under the chair. So that's just something worth mentioning. And then don't forget the feet. Now, even though considered generally a dynamic, load-bearing body segment, actually in sitting, it's really key for postural stability. The feet take 19% of our body weight in sitting, and that's a significant portion if feet are unsupported. I'm sure you've probably walked into environments where somehow the foot plate has disappeared, it's being used as a bookcase or a doorstop. It's really key that we get the feet supported. We naturally seek that feedback, so we need that proprioceptive feedback to get that pelvic stability and postural stability. What we can see without that is an increase in tone, an increase in involuntary movement. So it's really key to help dampen down some of those movements, especially for comfort and function as well, to get the feet supported, to then support the pelvis as well. There are different options for different foot support. If somebody has good range of movement, then they might just need something like a foot plate pad. But then if we are working with sadly fixed positions, then we might need something softer that just encompasses it. Another thing to be mindful of is that sensory feedback as well. If somebody has sensory impairment, maybe they only tolerate firm support surfaces, or maybe they only tolerate softer. Then we can look at that in the seating solutions to make sure that we're not getting a negative response and increase in tone in response to it. So the third seating objective we had was function and independence. And as we know, especially with a child, this is really crucial for their well-being and important for them to feel like they live in a fulfilling life. But it's also important to protect. So all these objectives lead into one another. That functional movement is really key to protecting body structure as well and reducing the risk of injury, getting blood flow to the area, taking joints through their range of movement to really protect and reduce the risk of body distortion as well. So they're all interlinked and they all work holistically together. Now, this freedom of movement and function is only possible with pelvic stability. So we can only get that freedom of movement in our upper limbs if we get that effective stabilization. What we can find if somebody lacks that stability, then we might see them clinging onto the arms of the chair or digging elbows into the corners of the chair. You might see tone increase and shoot through the roof as well. Involuntary movements because they're just feeling unstable and unprotected within the chair. So we need to get that pelvic stability to be able to allow the arms to freely move and engage in hobbies and occupation. And as I mentioned there about tone, so research has shown that seating and the way in which we set it up can influence a person's tone and reflexes, which is key to that encouraging normal movement. And then lastly, we had engagement. So this is really important for the psychosocial factors and well-being. If we can get somebody in a stable, upright sitting position, then we can encourage this participation at home. Head control, I mean, it seems pretty self-explanatory, but head control is essential for orientation, to be able to interact and communicate with loved ones, to get a good visual line, to be able to interact with the environment if it's needed. And it's really key for developing their communication skills as well. we get, as I mentioned, this better line for interaction, but it also allows more effective cognitive tasks, especially when we're working within paediatrics. We want that development. And if you're working with individuals who do have a learning disability or an intellectual disability, then we, of course, want to enhance cognitive function and communication skills, which are all precursors to improve learning and participation. So again, we've done lots of webinars in the past on the clinical justification. So if anyone needs access to any of these references, especially for funding requests and so on, then please do let me know, because it's really important when we put in these requests for equipment that we differentiate what those objectives are. A wheelchair will be very different to the needs of specialist seating, for example, and the nighttime positioning. But if anyone needs support on that, then please do let us know. So we said about being proactive with our postural care, and I've said this in that I can't stress this enough how important it is to identify risk and intervene in a timely manner before irreversible body distortion occurs. And especially within paediatrics, there's an increased responsibility on us, because when individuals come into this world, we do have these normal postures, and we want to protect that as much as possible. We need to use our resources to objectively identify those who are at risk and determine if there's a need there for a specific postural care pathway. So one thing we always say to individuals to think about those who could be at risk, and Anna gives some lovely images there to really give you an idea of somebody's nighttime or lying positions and how that can influence on their sitting positions, and how to identify those that might be at risk, especially with things like those that may be windsweep, those who fall with their knees together or in that frog-legging posture. When it comes to sitting, 3 things that we like to raise and highlight to people is to think about, of course, those that lack the physical ability to change position, those with limited active movement who can't physically change their own position are going to be at risk of body distortion. But we've also got those who lack the cognitive awareness to know that they need to change position. Those who maybe have a global development delay, or maybe they have a learning disability or an intellectual disability, and they don't know that they need to change position, or they don't know that they are uncomfortable. It could be a sensory element to that as well, so they don't have the sensory feedback to know that they're uncomfortable. So we need to think about those types of individuals. But then also those who lack the communication skills as well to convey. So they might very well know that they're uncomfortable, but they can't convey that, they can't communicate that they need to change position. So when, in terms of identifying risk, in the simplest of terms, breaking it down in those 3 types of individuals. And if you're working with anyone who presents in this way, let's definitely start thinking about those postural care pathways, how we need to address that full 24 hours. And some resources as well. Again, it's a lot of information to kind of get through in an hour. That's all we've got with you. And there's a lot of resources on the website, and as Anna said, she'll share a lot of resources as well. But if there are any specific questions, if we don't get around to answering them today, then we'll get in touch with you and share any links or resources. But the website is a good starting point. The CareFlex website, we've got an info centre on there that's got all the downloads for postural challenge booklets, clinical justification documents, and so on. So please do just get in touch if you need more information on those. Okay, let me just get Les back on the screen.
Okay.
Sorry, Les, I haven't given you much time here.
Well, I was going to mention it. You've stolen all my thunder and all my screen time. So I'm very aware we are kind of running a little bit over time. I will just very, very quickly run through key features, if you like, of specialist seating and things to look out for using 2 chairs from our range here. 2 chairs I have with me is the HydroFlex and the Hydro Tilt, the mini Hydro Tilt. Broad brush, the main difference between the 2 chairs is that the HydroFlex is tilt in space with back angle recline and an articulating leg rest. The Hydro Tilt is tilt in space. It's a very simple chair, but it's quite deceptively adjustable as well. So tilt in space, again, I don't want to teach anybody to suck eggs, but the whole chair tilts. The angle between the seat and the back remains constant, which is a big plus point for pelvic stability. Key thing I'd always bear in mind and consider for our form of seating is, especially with children, is adjustability, future-proofing. So with the mini tilt, for example, we can adjust the seat to floor height retrospectively. There's built-in adjustment for seat depth, and there's built-in adjustment for seat width. Very simply, peel the arm off and put a thinner or thicker arm onto the chair.
And this is really key for pelvic stability. Getting those measurements right is critical to making sure that pelvis is stable.
Range of straps and harnesses to use with a chair, very similar to what you find on your standard wheelchair offering. Pelvic strap, 4-point pelvic strap, chest harness, groin harness. We can fit a pommel to the chair. Head support, this is just one style of headrest here, so it's called a neck headrest there, so it would really prompt that person to sit in that midline position. When I say prompt, our form of seating, we're always trying to balance and compromise comfort, as Rebecca's mentioned, and the clinical postural support to try and keep that person in a midline position or accommodate them to prevent further decline of their posture. So this is one option for head support. Foot support, just a simple flip up foot plate. The beauty of the hydrotilt foot plate is very strong and very robust. So if you have somebody who spasms and extensive spasms and really putting a lot of pressure through the foot plate, really strong, robust option. The other thing to point out again is that what I have with me, as you see, the two chairs are very much standard and off the shelf. And quite often with paediatric clients, we're looking at bespoke, tailor-made solutions, custom-made devices. So never be afraid to ask us for something a little bit different to what you see on the chair. For example, with the foot plate, we could add ankle shoulders, okay? This is just my assessment rate, but I'm sure you're aware of what these are. You've probably seen them on wheelchairs. A standard water cell technology pressure cushion. It's a flat cushion. We are starting to use ramps to give us different angles of seating. We're also using contoured and ramped cushions as well. HydroFlex, again, we can change the seat width and seat depth. We can adjust the seat to floor height as well. Tilt and space chair.
Just to say as well, I mentioned about some of the functions and accessories and making sure that we use them appropriately and safely. I appreciate we haven't got much time with you, but we have got, as I mentioned, a webinar that talks in a lot more detail about how to use chair functions safely. That goes into a lot more detail about things like tilt and space and positioning aids, lateral support and leg rest elevation and back angle recline, because there are going to be certain cases, things like catheter use. If somebody's got dysphagia, they've got an issue with pooling saliva, and there's certain functions and accessories might not be suitable. So just to say that if you want more information on that, then please do check out that webinar.
So again, tilt and space. You'll see that this chair tilts forward slightly. So if you do have somebody semi-ambulant, it's a very nice feature to get somebody's feet flat on the floor so they can stand to walk. Tilt and space 30 degrees, same as the hydro tilt. Back angle recline. The rear of the chair is controller, which we can isolate. So if you've got, inquisitive siblings or carers who don't quite understand the importance of back angle recline and the consistency of use, we can disengage the mechanism so it becomes a tilt and space chair once we've set the back angle. Hope that makes sense.
Yeah, if somebody has pelvic instability, then back angle recline can actually increase their tone. If they don't have their pelvis supported adequately, then we can see the effects that has on their stability within the chair.
Just an option for back support here. We have a contoured back support. So again, comfort, helping to prompt that person to sit in a midline position. Or we could be using a flat back with adjustable laterals. So we can pop these onto the back of the chair, different shape. That's a kidney pad. It's a standard pad there. And we can offset, we can increase, we can bring one in over the other so we can accommodate a more asymmetric body posture. So that is a really fly through of the products. I'm very aware, I'm sure we've got lots of questions. And perhaps, Jess, if we could move on, have you got any questions that stand out?
Yes, so could you give a little more detail on how to position for derotating the chest?
One for Anna.
Hello, I'm here. Yes, so derotating the chest is very simple. What we do need to start off though with is a level pelvis. So someone needs to be in a supported supine position. Pelvis as level as you can get it, because if the pelvis isn't level in the lying posture, all of that rotation will be feeding up through the lumbar spine into this flexible dynamic part of the body here. So derotation wise, we need the pelvis as level as possible. And if someone's rotating in a clockwise direction, we need to anti-clockwise derotate them. So you block in the side you want to take them to first, use the positioning system to gently roll them to bring that sternospinal line up, and then you block in on the other side. Key point though, certain positioning systems, you cannot derotate the chest in. So if you have a positioning system, which is a lateral positioning system, for instance, one that kind of sandwiches people like this, for instance, or if you've got anything with a stretchy base, a stretchy kind of, kind of bottom layer, you can't derotate the chest. So again, it's really important to know what's happening at the chest, so then you can kind of dictate what sort of positioning system you're going to need to use if you've got rotational distortion. There you go. Thank you.
Thank you, Anna.
Seating as well, always going back to the pelvis, stabilizing the pelvis, and then from there, then supporting as we work up the different segments within the chair.
Back to you, Jess.
Yeah, so another question was, how do you know when you can correct or accommodate?
I mean, when it comes to any kind of postural assessment, it's really hard because it's going to be completely individualized on the individual. From experience, from especially in the training days that we do, a lot of it comes to actually the confidence in getting hands-on. And sadly, we don't have X-ray vision, so we can't really tell what an individual presents like unless we get hands-on to see how we can manipulate. When it comes to seating assessments, we always do it in different stages. So you would have a look at their unsupported sitting posture first in their reference chair, then what they usually sit in from day to day, and then get them into supine lie-in, which then falls in nicely with kind of Anna's supine positioning, to actually see how we can manipulate and how close to that anatomical position we can get someone in supine lie-in, to then see if we need to correct or accommodate back into sitting. So it is a lengthy process. Certainly from learning disabilities services that I used to be in, some of these postural assessments could take 3-4 hours to get, especially with complex individuals, to get the information that you need. But it is all seeing how much we can manipulate the body and get hands-on. One key thing I would say is that if you are doing supine assessments, or any kind of sitting assessment, when you get someone out into supine, giving them that time to relax and to settle first, because especially with some movement and handling procedures, somebody's tone could actually increase, and then we're not getting a true indication of what they're able to do with the body. So allowing them time to settle into that position, to relax into that position. And then when you're getting hands-on and maybe starting with the pelvis, if something is uncorrectable, then you will see all those other body segments move when you move the pelvis. So what you'll find is that if actually that pelvis is now fixed and we're starting to manipulate in lie-in, you'll see the shoulders coming with it. So that's one key point. I don't know, Anna, if you've got any more tips to do with that.
Yeah, so very similar kind of theory, really, in the sense that generally, like I'm the kind of person that would always say that I don't. You can generally do a huge amount with someone if you really take your time. So exactly like you just said there, kind of that idea of looking at our before and after photographs, particularly, so Tommy's story, people will often say to us, oh, I would have looked at him and thought that he was fixed. And actually it's that kind of understanding that it's a very gentle, gradual approach, looking at nighttime positioning and derotating the chest and kind of unpicking these complex body shapes. Before and after photographs that we have, the minimum that we have between those fit pictures is months, and the kind of, some of them it's years. So it is just about taking a very gentle, very gradual approach to changes in position when it comes to making sure that people are comfortable.
Yeah, the review is key as well. But there's one thing we always say about seating is that, especially from CareFlex, if you have a chair prescribed from us and there are issues a few months down the line, or maybe you think actually we can correct a little bit more, or actually we're getting some issues and there seems to be some redness that wasn't there before, then that part of our service is coming in to help you review that as well. and making sure that the chair is still set up, and maybe we need to tweak it. And the beauty with seating systems is that, as Les said, retrospectively being able to change things gradually to try and get that objective. It's not going to be, as Anna said, an overnight solution, especially when it comes to things like involuntary movements and high tone. We really have to be gentle with that approach.
And from a non-clinician's perspective, I'd recommend the Oxford Brookes course as well. Something I went on last year. It's a 4-day course, and it really looks at complex disabilities and measuring in a lot of depth. So if you want, you can Google that. It's the Oxford Brookes Complex Disability course, I believe.
I don't think Les has got any royalties in it.
No, not at all. No, my auntie's done well on it.
That's a joke.
Can I jump in very quickly just on that front and just say as well that when it comes to the lying posture, again, there's some research that looks at kind of how long it takes people to get used to positioning systems, that is in sleep systems themselves, and the average length of time is over 70 days. So that thing of, like you just said there, that idea of kind of it's so gentle, so gradual, and you need to have that. So what we do as an organisation is we have a kind of unlimited review service, kind of, you know, where we can jump in, particularly for those first few weeks of using a system, because they're always the most challenging, because we're dealing with sleep, we're dealing with nighttime, we're dealing with, you know, kind of all these different things. So the more often we can kind of check in with families and kind of give them that support and give them that confidence and that kind of, you know, that idea that, oh, yeah, we are using the system correctly. But obviously, like I've showed you before with those before and afters, nighttime positioning will need constant tweaking, constant changing, particularly if we're looking at restoring body shape, and that's really exciting. But obviously, it then involves a lot of kind of, you know, involvement from a clinician point of view and from our point of view. But that's kind of what we do.
Anybody else, Jess?
Yes, so another question was, is there a standardized assessment form out there that can be used that helps to determine where the postural supports are required?
I think that probably for both of us to answer here, Anna, from a CareFlex point of view, we have got, I mean, we haven't got a generalised one that they hand out, but we have worked with trusts and teams and organisations to help them develop an assessment performer, if that's what you mean, in terms of being able to assess someone before doing the seating assessment, the types of information that we would need to know to maximise the seating assessment.
Like a triage.
Yeah. So we have got those. If there was a particular need for that, we can support and develop an assessment performer that would need to be filled in with some guidance before getting in touch with CareFlex. And I don't know if you've got the same type of thing.
Yeah. So if you're thinking about the lying posture, there's some great resources like the Mansfield checklist and things like that to have a look through. So that's looking at kind of, you know, sort of segmenting the body and kind of checking out kind of what's happening at each kind of area, so that you can then you know, decide what you need to do. I'd also recommend looking at things like, so if you're looking at things like measurements, so with regards to protection of body shape, the best practice kind of reasonable adjustment guidance that came out a couple of years back looking at postural care cited that people should be using objective validated measurements of body shape. So again, we've got kind of work on that where you can take measurements of people's bodies, work out what's happening with regards to your rotational distortion, compression distortion, wind sweeping, things like that. And then you can plan far more effectively your positioning strategy once you know those sorts of things as well. So yeah, so I'd say Mansfield checklist, Goldsmith indices of body symmetry, you know, really kind of key things to have a look at for people.
Yeah, definitely getting that objective data as a baseline to make sure that what the intervention that you put in place is actually having the impact that you want it to have. So things like, especially when it comes to seating, to see how much maybe lateral flexion there is at the trunk, and measuring actually in a corrected position what the measurement is from the ASAS up to the coracoid process on both sides, and you can get an objective idea then of how much lateral flexion is happening, to make sure that once we've got the chair set up, if we review that to make sure it's set up in the right place, things like lateral supports have to be put in the right place. It's just a physics thing to make sure that we get in the impact that we want in sitting at the right parts of the trunk. So definitely the objective data for baseline measurements as well is really, really key.
Next, Jess.
Yep, I think this is our last question. This is one for Anna. So we had someone wondering whether you've done a similar webinar for parents. They said that all the points would be so valuable to get across, but they might need a slightly softer approach.
Yeah, so we do completely kind of free of charge family workshops and webinars and things like that. So the approach will be sort of, like you say, slightly softer, but very much they have to have all of the information. They have to have, these are our risks, this is what we can achieve if we get it right. So kind of, we very much believe that if we need families to kind of engage with this and to be really motivated to use particularly sleep systems, because they're not easy, I'll be honest with you. You know, it's sleep, it's nighttime, people are sleep deprived already. So to be really motivated to use a sleep system, you know, we need families really well informed and kind of, you know, sort of inspired to kind of get on with it. So we do, you know, big believers in making sure that families have got access to the right training and the right information. And yet we do webinars and training sessions and stuff like that for families, you know, care teams, whoever really will sit still long enough in front of us, we will happily talk to you about this.
I can just see a question there from Bethany. Yeah, the HydroTilt does have water compartments in the seat cushion. Yes, water cell technology. That it then, Jess?
Just having a quick look through. I think that's all of our questions, but of course, if there are any more that you think of, just email us at info@careflex.co.uk.
And we'll obviously get all the resources as well together, and Anna and ourselves will email everything out and links and any resources we think will be useful.
So we'll draw things to an end. And just to mention as well, our next webinar is the 17th of November, and it's tying in with Pressure Care Awareness Week. So if you'd like to sign up for that, visit the website. I'd like to thank Anna.
Yeah, thank you very much, Anna.
I'd like to thank Rebecca as well. That's it. Have a lovely day. Hopefully we'll see you soon. We're at the OT show as well, I'm sure. Are you there as well, Anna?
We're not there this year. No, we're not, unfortunately, but we will be hopefully in the next year. We're planning our events for the next year, so it'll be good to be there.
Okay, well, thank you everybody. Enjoy the rest of the day, and we'll see you again. Thank you.
Thank you. Bye.
Bye.
Thank you very much, everyone.
Bye.